And we're live, Charlie. Go right ahead.
All right, great. Thanks, everybody. I know I've got the sunlight behind me. I know with this all new Zoom over the last year, it's been a little challenging. So sorry for the lighting, but it's not professionally done. I appreciate your time, and we're going to hopefully share some good information with you today. We want this to be interactive. I know there's a tremendous amount of people on the meeting, so please submit your questions to Tyson, and we'll try to answer as many as we can. And if we can't get to them, we'll get to you. We'll call you back afterwards, or certainly get back to you. Also, we have no problem sharing this presentation. So at any point at the end, if you want a copy of the presentation, please let us know. We're going to go relatively quickly. We've got an hour here, and we want to review quite a bit of information. And let me start off by just doing some introductions and tell you what we're going to be going over. We're going to go over pharmacy benefit overview, what's driving specialty trends. Certainly everybody's aware of specialty and the cost and what's going on there, but we want to kind of dig a little deeper and shed some light there. A comprehensive approach to specialty management trends, as well as some case studies at the end. If we have time, we'll go over the case studies. So with the introductions, I'll introduce my staff for them, or not my staff, my equals for them, and then they can go into themselves as we get into the presentation. Obviously, you guys can all read. I'm Charlie Hartz. I'm the Executive Vice President for NFP RX Solutions. I've been with the firm for just about 10 years now and cover the entire country. We have Nellie Rose, who's a pharmacist. She's the VP of Pharmacy. She's been with us for just over 4 years, I believe now. And she heads up our entire clinical team and oversees any clinical programs and or specialty programs that we may have or challenges that are in the marketplace. We've also got Nick Conway on. Nick Conway is the Senior Vice President and Head of Product and Analytics. So what that means is he works with all of our vendors and manages those relationships. He also oversees any of the data that we take in and or produce back out to our clients to kind of give them information on what's going on within their particular pharmacy arena. So what we're going to go over today, and this is just a brief summary of who we are. I'll go over this relatively quickly, and then I'll turn it over to Nick and Nellie. But NFP RX Solutions, in a nutshell, I'm not going to read the slide. I'm more of a hands-off, just talk to it. We are a PBM consulting firm. So we're not a PBM, but we're a consulting firm, and we work on behalf of the client. And so we are essentially a watchdog over the PBMs to make sure that they are giving the best cost, the best rebates, the best service, programs that are available to our clients. The PBM portion of your benefit can be very, very confusing and very overwhelming. And with that, we try to uncover some of those games that they play and expose our clients to better opportunities and better savings and programs via our coalition. So as you can see, we're actually physically based in St. Louis. We've got 8 pharmacists on staff, 12 account executives, as well as 8 pharmacy analysts. We've got over 1.5 million lives in our coalition, and really what that means to you, and let me define what that means when we say lives. It's physical belly buttons. So it's the employers and their family members that are a part of our coalition. It's comprised of over 300 clients all across the United States. But what 1.5 million lives should mean to you, hopefully by the end of this, you'll get a feel for it, is we use the size of our coalition to drive costs down. So we use the size of our coalition to work with the 3 major PBMs, as you see there, CVS, Express Scripts, and Optum. We work with the big 3. We can work with other PBMs as well. We just traditionally don't get as good of pricing as well as good of rebates. They might have a little better customer service. The big 3 are a challenge there, but that's why our company exists, is to help you through those tough customer service issues. But what we do is we leverage the size of our coalition to help garner better pricing. And so what that means to you is if you're with a company that's got 200 lives or 5,000 lives, it doesn't matter. We have already pre-negotiated our contracts with the PBMs, and we don't allow underwriting to be biased and say, oh, you're a 200 life group, you get 200 life pricing. We try to eliminate that and say, no, they're part of the NFP RX Solutions Coalition. they're going to get this pricing. So the 200 life group is getting the same pricing as a 10,000 life group. What we're seeing across the board, and I will try to continue to move on a little quickly, is traditionally what we'll do is we're going to do an analysis for you, and we'll look at your data and show you what you could save if you were within our coalition. And what we're seeing there is an average of about 20 to 30% savings across the board. So if you get nothing else out of this presentation, at the end of the presentation, the company you're working for, if they're questioning, if you're having challenges with your cost within the pharmacy portion of your benefit, have us take a look at it. Cost us nothing to look at it. Reach out to Tyson, and we'd be more than happy to look at your data and say, you know what, you've got a phenomenal contract. What you're doing is great. Continue to do that. Or, hey, your contract isn't up to market value or up to market competitive. And oh, by the way, there's a couple specialty programs or clinical programs, utilization management programs that we could put into place for you. So at the end of this presentation, all of the stuff that Nellie and Nick are going to feed you is what we do every single day. And that's all we focus on is the pharmacy portion. But if at some point you say, you know what, I should at least take a look at what we're doing, that's what we're here for. Some of the things, I'm not going to go into all 5 bullet points here. I'll just highlight them. If you're working with Tyson and our firm, some of the things that you're going to get from us is financial and clinical savings analysis that I just spoke to. Management strategies, we'll look at your trends and come up with different clinical programs that we think would fit your culture and what's going on with you and your trends. Every single account that we have has a designated team. So you'll get an account manager, a pharmacist, an analyst, as well as an implementation manager. So the heavy lifting is on us. Our job is just to help make it a smooth transition and again, at the bottom line, mitigate costs for you and expose you to opportunities. We've got a service center that's available to you. Normal business hours, you can reach out and get prior auths and different things taken care of that are ancillary. And sometimes you don't want to get lost in the big PBM abyss of those 800 numbers. You can call us directly. And then we've got, of course, data analytics. Data is power. The more information we have, the easier it is for us to manage your benefit and help reduce cost. With that, I'm going to turn it over to Nick, and he's going to go over some of the pharmacy benefits of what we do and how we manage it.
Yeah, and this is Nick Conway, and I'll start real high level before we get to Nellie, who's really going to drive into a lot of the clinical things that we do and that you should be looking for as an employer. But from the very basics of what is pharmacy benefits is about 1/10 or 10% of a $3.8 trillion healthcare industry in the United States. It brings together some of the largest companies that our country has to offer. And in fact, 6 of the Fortune 10 companies actually have a component of their business in the healthcare and benefits supply chain. And so the way I like to break it up, or the way I like to look at it from an employer's perspective, is pharmacy benefits is bringing together the manufacturer, which is actually the physical manufacturer that is making the medications, the distributor or the wholesaler. So as you see there, AmerisourceBergen, McKesson, Cardinal Health, those may not be companies that you're familiar with, but it's about a $480 billion industry, which are essentially the vendors that bring the prescriptions to the point of sale. So the point of sale can be, as you see, pharmacies. It can be a retail pharmacy, a mail order pharmacy, or certainly something we'll talk about more, specialty pharmacies that are growing significantly in our industry. Charlie, you want to go to the next slide? And so if that's pharmacy benefits, what is a pharmacy benefits manager and what are their responsibilities? They're really the glue that allows your members to seamlessly get their prescriptions at the point of sale. And as a member, they should only see when they get that prescription as a product of their insurance benefits. So the pharmacy benefit manager, by bringing together the manufacturer, the distributor, and the pharmacies from the previous page, is actually going to be your contracting entity, right? And so there's over 60,000 pharmacies across the United States that they contract with, and they have individual contracts with each individual pharmacy chain. They will contract with the manufacturer, and when you hear about rebates and the value, that's actually your PBM negotiating directly with the manufacturer to have value brought back to your entity. And one of the reasons why we primarily work with CVS, Optum, and Express Scripts is because that leverage in that particular negotiation, where they're negotiating directly with the manufacturer to bring value back to the payer, is something that can really differentiate themselves from the large market PBMs to the small market PBMs and drive additional value. And the third thing that they also do is they are the administrator of your benefit. And so what we mean by administrator, not only are they processing the physical claims, so making sure the technology works, right, to make sure that when a member actually shows up at the Walgreens pharmacy, pays for their prescription, and that it gets back to the benefit. But more importantly, they are providing us the tools that we have to provide clinical oversight for our plans and managing the plans. And what I mean by that is if you had an open benefit where there's no management at all, if you were allowed to go get any prescription you like, our estimates are that you'd spend about 4 times as much on your pharmacy benefits as you do today. So without prior authorizations, without step therapy limits, without specialty copay programs, which we certainly administer, without that additional value, you're going to spend significantly more. And the way we look at it as a firm and why that's so important from a coalition perspective and leverage, as Charlie talked about, the contracts are one component of savings, but that clinical oversight and administration that we have in the bottom right hand is just as important and provides just as much value for our clients. Charlie, you want to turn to the next slide? And so the next question is, why would you work directly with a PBM versus going through your carrier, for instance? And what we're finding is we work up market, is about 96% of the Fortune 100 companies have carved out their pharmacy benefits. And that's really for the 4 reasons that you'll see on the left-hand side. They provide clinical solutions. And what we mean by clinical solutions, and what we just talked about on the last slide, is we're able to look at an individual therapeutic class and be able to administer a clinical solution that targets our problem areas. And so when a benefit is carved in, what we find is that you're stuck with bundles, right? That says, hey, let's do high, medium, low in regards, and we'll pay for it in this way. Well, for us, that's not sophisticated enough. For us, we want to be more aggressive along the targeted areas, and we identify those targeted areas through analytics, right? So our team has set up algorithms to identify certain problem areas that we can say, hey, we need to start looking at your diabetic population. We need to start looking at how to manage high cost members because we see this trend increasing. And so data is the second component of why a company needs to carve out, at least in our perspective, because that's going to provide them the data to be able to manage their plan. The third portion is account management. So when you're carved in, your account management team typically has expertise on the medical side and not as much responsibility on the pharmacy side. So by carving out to a PBM, you really get that SME. You get someone that really understands the issues that you're dealing with, that can quickly manage those and build a very successful pharmacy benefits program. The fourth and final thing, which to Charlie's point earlier in the conversation, is becoming the most important part of why you should carve out and why you should work directly with a pharmacy benefits manager. The specialty benefit component of your pharmacy benefit is now approximately 50% of the total cost of your prescription medications. Most of those medications didn't exist 5 and 10 years ago. And so as we start to navigate this new area of the pharmacy benefit, we have to say, how do we do the best job at making sure this is the appropriate medication at the right price at the right time? And so that's, Nellie will talk much more about that, but that's why we feel that contracting with a pharmacy benefit manager provides a huge, huge value. Charlie, you want to go to the final slide? And so this final slide just really talks about carving in versus carving out. And I think one of the key areas to carving in, right, it's a little simpler. Typically, then the plan will only have one ID card. That's traditionally what we find is the biggest differentiator for the member. They don't notice much change when you're carved out versus carved in, except for they typically have an extra ID card. The benefits certainly outweigh the negatives, right, of carving out. And so talking to what Nellie will speak to of how we manage high cost medications, how we're going to start managing trends in regards to new programs, new clinical advice to provide additional value is the biggest benefit of carving out.
Thank you, Nick. So I'm going to take it from here, and I'm going to start at the 10,000-foot level, high level, showing you what spend looks like around the world and US spend, and then go a little bit more granular to things that may be familiar to you in what you may have seen with your clients on pharmacy spend. So across the world, US has the highest spend per capita. We've known this. Drug prices have been a huge focus in our industry. Drug importation has been a big focus in our industry. But as Nick had mentioned, pharmacy itself only drives 10% of our total healthcare spend. Our major drivers of healthcare spend include hospitals and professional services. But outpatient prescription drugs have had a year-over-year growth of over 5% that have, equated to almost $400 billion in RX spend. And what we've seen with that is just a shift in the pharmacy paradigm away from traditional therapies for chronic conditions to more novel therapies. So if you will go to the next slide, Charlie. I wanted to share with you guys some of the PBM trend reports that I look at on a daily basis. I try to understand what's driving trend, what the components are, how we can understand it from a big picture, and how we can implement it to our individual clients for unique solutions. So this was based out of the 2019 drug trend reports. We're just now getting 2020 drug trend reports from our PBM partners. But one thing that we know for certain that we've been seeing year over year is that the specialty trend has slowly but surely increased to over 50% of your total pharmacy spend. And I think what's really important to understand about that is that it's a very small population of utilization. So a rule of thumb, when you try to understand specialty, 2% of members are driving 50% of cost. Okay, so you've got an industry that's up to 90% of generic utilization at this point. but your 2%ers are really the ones that are, you know, shifting the needle in your planned spend. So to understand more of those components, you really have to understand what's driving trend and what are the components of trend. So the three components of trend are obviously drug mix, the utilization of the products, meaning prescribing, an uptick in use, and then the price of the products. So I'm going to break down each of those for you. And Charlie, if you can go to the next slide. So one of our trend components is certainly the price. It's no news that brand name drugs have historically been inflating in cost more than the U.S. Consumer Price Index. So we've had about 2 to 2.5% increase in inflation for your common household goods, but almost 7% inflation on brand name drugs. And what we've noticed on that is that as this shift is happening to more specialty utilization, 5% is starting to add up to significant dollars when you're talking about high cost therapies. But what I think is a little deceiving in how, the media and certain bloggers are posing the inflated drug cost is that you don't necessarily have to absorb those inflated costs if you manage your contracts and your benefit appropriately. So if you look at the graph on the left, we have seen that the list price of the drugs have had inflation year over year. The last few years, there's been a huge focus on pharma list costs that have driven some of those list prices down, but they're still in that 4 or 5%. When you think about 4 or 5% of $10,000, that adds up. But what's really important and where we really focus on our job is that net price growth. So when you think about what a net price is, that takes out discounts and rebates. So when you net out the AWP cost of a drug, which is equivalent to what you would consider an MSRP, once you take out discounts of each individual drug and then net out the rebates that we contract year over year, you actually end up having a negative trend. So that's where it's very important to have a team to help support you in understanding where these shifts are moving to and how you can renegotiate your contract, whether it's market check analysis, auditing, repricing, or just, competing your PBMs against each other. Those are the strategies that help bring that list price down to that negative net price. And so the second contributor of trend is the utilization. So as Nick had mentioned, 5-10 years ago, some of these drugs that you're seeing in your top spend didn't even exist. In fact, when I started in this industry almost 5 years ago, it was a real big shock to me. I really wasn't understanding how all of this suddenly became such a big bubble burst. And over the years, we have started to truly understand where things are going and how we can evolve our strategies as the market evolves itself. So we've seen, major trend year over year, driven specifically on specialty. Now, I don't know if you are familiar what's considered a specialty product, but they're not the same kinds of medications that you may go to pick up at your mom and pop retail shop or at a Walgreens or CVS. These are biologic agents that have very strict administration and handling. A lot of them are injectable products that have a lot of regulatory restrictions around them and need very tight management and counseling. So specialty products are actually dispensed through specialty pharmacies for those reasons alone. And as Nick had also mentioned, specialty pharmacies have had a huge uptick and popping up left and right because of the major need in our industry and the growth of specialty products. So wanted to throw out a few interesting stats for you. The number of specialty drugs have grown 166% in the last 10 years. We're going to keep seeing a year-over-year trend of about 20 to 25% in the uptick of new utilization, okay? Where we do anticipate the peak to really level off will be right at 2023. So in about 2 to 3 years, we do anticipate that this trend will start to slow down a bit as new specialty products start to lose their patents. So, something that's very interesting right now is about 95% of specialty drugs are still brand name. And many of them are not going to lose their patents in the next 5 years. So the original products, your Humiras and Enbrels, inflammatory conditions medications, those patents are set to expire right around 2023. And that's when we should anticipate a little bit of cost relief in those categories. But there's other trend drivers, and I'll discuss that as well. Okay, Charlie, can you go to the next slide? So we notice that the utilization of specialty is increasing. We know that the cost of the drugs are inflating, but the third component of trend is your drug mix. And understanding, well, what are the therapeutic categories? What are the drugs that are really shifting your spend? So across the industry, we have over 300 clients. We look at all of their data. We look at our PBM's data. And sure enough, always in the top 5, you're going to have inflammatory conditions, diabetes medications, and oncology. And one thing that's very important here is as you see the bar graphs are different colors. So the blue actually indicates that they're just a traditional brand name drug, the kind of medications you can get at the retail pharmacy. But the orange indicates specialty therapies. So as you can see, therapeutic classes that are dominated by specialty therapies are in your top 5 indications for planned spend. So again, like I said, 2% of utilization equals 50% of growth. We're seeing double-digit trends in these categories. And if you haven't been able to identify these categories, or if you're not aware of those are the components and the value that we bring to bring this to light, because your spend is going to increase if you have no awareness of what's driving it. So to make things a little bit more complicated, within specialty is an even more novel subset of medications called orphan drugs. So orphan drugs are still considered to be specialty, but they get their own FDA designation because they're actually intended to treat rare conditions. And so a rare condition actually has a threshold. In order for a drug to treat a condition to be rare condition, it has to only impact less than 200,000 people in the United States. So that's a 1%. Some rare conditions that you may or may not be familiar with are hemophilia, cystic fibrosis, oncology. Cancer is a rare condition because they vary specific to the certain organs or blood disorders. And then even more recently, we've seen rare conditions in the enzyme categories. So what's very interesting is within specialty, we've seen a huge pipeline, huge uptick in utilization, but the biggest uptick within that has been with orphan drugs. So an orphan drug costs, I would say at this point, more than $140,000 per year. That's a conservative number at this point in time. But, there's still so many rare conditions that have not even been tapped into. And so we're seeing that about 58% of our specialty pipeline consists of novel agents targeting orphan drugs. Okay, Charlie, and if you can go to the next slide. And then even more costly therapies target around gene therapies. And I know that this is a very foreign concept to most of you at this point. You may have heard of gene therapy or maybe one gene therapy, But what's important to understand is that this is the way that we're shifting. We have moved away from mass chronic management of traditional disease states. So, blood pressure therapies, cholesterol medications, even some of diabetic oral medications have really, saturated the market at this point, in which there hasn't been much focus in new technology and innovation. And then you've got a different focus moving towards more specific underlying conditions and curative therapies. So, trying to get away from the daily tablet every single day to, more monthly therapy or maybe yearly therapy to maybe even just a one-time treatment. So we've actually seen quite a few gene therapy drugs come into the market in the last 3 years. We currently have 4 common gene therapy treatments. 2 of them are for blood cancers. 1 is for actual blindness, inherited retinal blindness. And the most recent one, which I think has been a big blockbuster drug that really caught everyone's attention, was Zolgensma. And it was a $2.1 million curative therapy for children with SMA, which is spinal muscular atrophy. So we're seeing a huge pipeline and focus in these one-time curative therapies. What we don't know right now, and we're in the infancy of gene therapy, is, is the cost worth the long-term effects? Because we haven't had enough understanding post-clinical trial to really say, yes, a $2.1 million therapy is worth its price because it has extended life for X amount of years. So that's kind of the gray area that we're in right now, in understanding how to manage gene therapies. But as quickly as we've seen new drugs come to market, and how many we're seeing right now in phase 3 clinical trials, we're noticing that we're spending a lot of time educating our clients and consultants on what the future of gene therapy looks like and how we can start to manage it, even if we're not seeing utilization just yet, because it's the when. I think some of the focuses that we have seen have been around hemophilia, cystic fibrosis, even HIV for gene therapy. And last of all, what is our anticipated outlook look like? I feel like I've kind of tackled all of this, but to summarize it all, specialty is still going to keep increasing year over year. The biggest driver outside of inflammatory conditions is oncology. And in fact, 4 of the 10 blockbuster drugs, anticipated big selling drugs of 2021, are in the oncology space. So oral oncology, oral chemotherapy agents. And we're seeing that uptick already happening. We started to see that at the end of 2020, and we're seeing even more into 2021. That's really good news when you think about the innovation of our industry, is to move from, medical spend onto some of the pharmacy spend that's a little bit easier to manage, but you have to know how to manage it, and you have to be able to see it. And if you are, carved in, you may not have that transparency to know where those segments lie. So with that being said, I'm going to move on and pass the baton over to Nick to talk about trend management.
So I think from that perspective around what are the costs, how do we understand the players that are in the marketplace and understand where the revenue is going? What do we do now from here? And I think one of the things that Nellie said was, we're continuing to see as an industry the uptick in specialty medications, but our goal is to not bend the cost curve. It's how do we start breaking it, right? How do we not have our clients experience a significant trend? How do we put measures in place that reduce our risk exposure to those high cost medications. And so certainly as you'll see on this slide, is we have to use all the tools at our disposal, right? There's formulary strategies, which I'll say are what the PBMs put in place 10, 15 years ago. And then as you look to the right on that circle, you're starting to see more of the innovative cost structures. So outcomes-based pricing, copay funding, right, for the cost of the prescription. How do we maximize what we can potentially get out of the manufacturer? So as you potentially look at that Zolgensma prescription that costs $2.1 million, how do we offset that cost to the manufacturer, or potentially even have the manufacturer pay for it? And those are the innovative kind of cost structures and mechanisms that we're putting in place for our clients that are bending the cost curve somewhere between 5 and 10% outside of the value of the contract. And so that's where we're seeing a huge improvement for our clients that says, if I keep doing the exact same thing, can your contract help keep me relatively flat? For most, the answer is yes, potentially, as long as you don't get hit with that high cost claim. So really, we start putting in mechanisms that say, hey, not only can we reduce your exposure to those claims, but we could possibly even bend the cost curve further down because we can eliminate or reduce that cost significantly. Nelly, you want to go to the next slide?
I'm trying. Oh, no. Frozen on me. Sorry, guys. Hang with me.
Hey, Nick, while Charlie's working on that, can you describe a little bit more on the copay assistance program, like what that is and how it works? Like, I don't know if many people have heard of that.
Yeah, real quickly, we started working with manufacturers in 2014 to identify copay cards that are out there in the marketplace to cover the member's cost of the medication, right? If you're on a very high cost medication that does not have an alternative, that's specialty medication, there's manufacturer dollars available. And so what we've done as a company is said, okay, if you had $100 copay on a $10,000 medication, that helps the member a lot to get a copay card. But how do we start bringing more value back to the plan? And so over the last 6-7 years, most of our clients have adopted a strategy of maximizing the dollars that are available on copay cards per prescription. And so as opposed to getting $100 from the manufacturer on that $10,000 medication, our clients are getting between $2,000 and $3,000 per medication. And so not only does the plan member win, right, by getting the copay card and is adherent to their medication, can afford it, but now our plan sponsors are reducing their cost on that medication by 10, 15, 20% on a monthly basis. And so that's really been a win-win on both sides. And by the way, the manufacturers have already underwritten this into their model. So if you're not taking a specialty copay card program, if you're not maximizing the dollars from the manufacturer, you're really giving it away back to the manufacturer. It's just free money for them. And so it's been an exciting program. Again, most of our clients are saving between 5 and 8% of their total pharmacy costs by putting that program into place.
And so we do all the looking for that, Tyson, just so you know. I mean, it can be really daunting for a client or a member to try to track down those copay cards. Nellie's team actually physically goes out and manages that process and does it for the clients. Go ahead, Tyson, sorry.
Yeah, so we've got clients that are using this program. That's why I think it's such a cool thing. But I think what you brought up is maybe how people may be able to relate to it is that when you see the commercials and it's like, get a 90-day supply for $10 or whatever, whatever the thing says, that's kind of what you guys have automated for a group plan to take advantage of. Is that a different way to maybe say that too, or?
Yeah, you're dead spot on. That's exactly right. And the challenge is those commercials, every single one has different criteria or different
Right.
things to meet or different things you have to, it has to be on your plan design, not on your plan design, or you at a certain income level. There's a lot of different, each manufacturer has different qualifications. We've vetted all that out. And so
Cool.
it's not arduous for your members to have to go out and track that down. We get identified via the PBM systems. We have access to the system. As soon as it's prescribed, our team goes into play.
Awesome.
And before they even know it, and traditionally, Nellie, correct me if I'm wrong, but to get specialty, that's where these copay assistants come into play, is on the specialty meds. And to get a specialty med, it traditionally takes anywhere between 5 to 14 days to get it. So it gives us that time
Mhm.
to be able to go out and track down the copay.
Awesome. Thanks so much.
Yeah, there's the next part that we wanted to talk about in regards to how to manage your pharmacy benefit is really setting up your formularies correctly. Starting off with system one, do you have a 3-tier plan design, right? Do you have a high deductible plan that will help members select the right medication in that particular therapeutic category? But from there, we started to get much more aggressive. And what we mean by much more aggressive is, are we starting to look at more sophisticated specialty tier designs? Are we starting to look for our employers at what would be considered a custom formulary? And the way we manage both of those is from an analytics perspective of saying, here's your utilization, here's what we anticipate you to spend, and here's the value that we can put in place by putting in this formulary design or putting in this exclusion. And we can work with those members and make sure that they're on the right medication at the right time through the right channel. And so what we've historically seen, going back to the conversation about should you carve in or should you carve out, is there's a lot less flexibility when you work with a carved in carrier. And so by us kind of bringing the expertise and giving you the tools to be able to provide a more sophisticated plan benefit, we are, through those methodologies, reducing plan costs by somewhere between 3 and 4%, right? So as we talk about breaking that curve, right, you start putting in the contract and the coalition level pricing. You start putting in a specialty copay program that's reducing spend by 5%. And now as we start to provide custom formulary management, right, we start to bend the curve another 3%. And so that's obviously a very sophisticated methodology. If you're working directly from a carved in perspective, we make that simple. We explain exactly what medications we're going to move, who the members are that are potentially impacted by that, and what their alternatives are. And by the way, we have a clinical team that will communicate with each one of those members to make sure it's a seamless transition. And oftentimes we're even talking with the member's physician who's going to agree with our methodology. If they don't, we can certainly override that and keep them on the same therapy. But again, we make sure it's the right drug at the right cost. If you'll go to the next slide. And so this is really from a CVS perspective saying, what does that formulary management actually mean? And so CVS was actually the first PBM that allowed for exclusions on the formulary. You typically, on an annual basis, somewhere around November, December of each year, see articles written about CVS or Express Scripts as excluding more medications and think, oh, terrible PBM, why are they doing this? And this is exactly why they're doing it as we start to look at the individual therapeutic categories. If from an unmanaged plan perspective, if you look at the all drug categories, or what I think is even more relevant here is you look at the statins, the PPIs, the metformin prescriptions, the antidepressants. In most of those categories, we're able to lower or reduce the cost as a therapeutic category by 30% by actually managing the formulary. So if you look at metformin, for instance, which is something that you need to be taking a look at in regards to your utilization. Make sure your members are taking the right metformin prescriptions. That's a $26 cost down to $14 just by having the appropriate formulary and managing the formulary. So again, huge wins. We find that it's the right medication at the right time versus opening up the formulary and allowing a member to get whatever they want. I'm going to add one thing to this that's not really a part of our presentation today, but pharmacogenomics is something that we're working with a lot of our plans on, and it fits directly into this formulary strategy and making sure that you have the right medication at the right time. And what pharmacogenomics is, it's actually an evaluation of your genes and how you're metabolizing the medications. And so as we look at metformin and making sure it's the right medication at the right time, we're identifying, particularly in these categories, if your body's actually metabolizing the medication correctly. Should you actually be on a higher dose so that it's more appropriate for you to take and you're actually getting the most out of the medication? Is it possible that one drug in your category is not going, or in that therapeutic category is not going to react correct with your genes, so you should be taking another medication? I think that's one of the more sophisticated approaches, is we not only look at the list of drugs that's on the formulary, but then starting to target the drugs that could be impacted by more sophisticated approaches. Charlie, if you'll go to the next slide. And this kind of just speaks again to that drug exclusion portion of the conversation. In 2014, when CVS started with exclusions, there's been about 26%, 53%, 19%. We're continuing to see an increase in the total number of drugs that are excluded, but we're finding that there are appropriate exclusions. And so a majority of the time, these exclusions are for prescriptions that we may have already taken off the formulary in regards to our high cost management program, because there was already a generic in that category, right? And so I always think of the exclusion, or the appropriate exclusion, as the Adderall medication, which we are all very sensitive to making sure that our children are on the right medications at the right time. But if you're choosing to be on an Adderall product versus the generic version of the exact same medication because you know what Adderall is, maybe that's the appropriate time where the actual brand of the medication had more power than the science behind the medication. And so we want to make sure that the branding that the manufacturers invest a ton of time isn't inflating the cost of our plans.
Yeah, and I do want to add one more thing to this slide. As you see year over year an increase in drug exclusions, it's actually a good thing, because year over year, we're also seeing hundreds, if not thousands, of new drug approvals. So for instance, in 2020, there were actually 757 new generic approvals, meaning that they already took the spot of a current high cost brand name medication. So by having more generics in the market drives more competition, and therefore having drug exclusions in saturated therapeutic classes is what we consider to be appropriate clinical management, because they're not taking away something that doesn't have a clinically equivalent lower cost alternative. So year over year, we've seen 900 to 700 to 800 drug approvals, specifically going generic. And then we've seen hundreds of drug approvals in the specialty category that have, increased the competition. So, it would be a different story if you're seeing more exclusions than you are approvals, because then that's being taken away. But it's almost a replacement of the same or clinically equivalent alternatives. So by having exclusionary formularies actually helps benefit your members to the lower cost alternatives they may not even be aware are on the market.
Yeah, so thank you guys both for the input. And I know, Tyson, if you're getting questions, I'm not aware of them, so I want to make sure that we leave time for questions. Q&A, we've got one more slide here, and then we've got some case studies that I don't know if we have time to go over, but the one thing I will say is obviously, just even from this presentation, pharmacy benefit it's overwhelming, and we're only scratching the surface here with what we've shared with you. Our staff is, and no pun intended, but a PBM consulting firm on steroids. I mean, that's all we do, and that's all we focus on. The great number that Nellie just shared of 957 new generics to market. If you're not managing your plan, you don't even know that, and you don't have the time or the knowledge to know to manage your formulary to add those to it to lower your cost. That's all we do, is look at opportunities to mitigate cost and better the experience. And so if that's of some interest, obviously this is the sales side of it, but Tyson, reach out to Tyson and he can get you a hold of us. But what you're seeing on the screen here, each of those 6 bullet points have 500 bullet points underneath them that we do. We do all of that for you on behalf of you. We do the heavy lifting. I just want you to know that there's somebody out there, if you're struggling with it, or if you don't wait for that specialty drug to hit, because it's going to hit. Nick said that. So Tyson, I don't know if you're getting questions. I don't want to not leave time for Q&A.
Yeah, we've got a couple that didn't come through the chat. That came through some other sources, but Charlie, your point about that is really critical. And I think the analysis is the first step. Obviously, companies have to be self-funded to be able to do this, or have another resource that has gotten the ability to pull the data, so that you guys can do what you do and try to figure out where the opportunities are at, all these programs can get put in place. One of the ones that comes up a lot, Nellie, I don't know if this is your space, but it probably is. But on the specialty condition side, the autoimmune and the anti-inflammatory obviously is the big one. I mean, Humira is probably, I'm guessing, is most of that, and probably others. What are some strategies that RX Solutions using for that type of class or that medications too specifically?
Yeah. So as Nick had mentioned, we actually have a specialty copay assistance program that tackles those exact drugs. So we find ways to do several things. First, we want to manage the network, right? You want to ensure that specialty medications are being dispensed through a specialty pharmacy. You don't want a $10,000 drug to be dispensed in 90-day supply limits like you have on your traditional space, because those drugs have pretty high adverse effects and turnover rate. So most of the time, in order to get somebody, situated on therapy, they have already tried maybe 2 or 3 different brands of a medication before they've gotten to stable state. So in order to get that for somebody, you don't want them to have 90-day supply at home just sitting in waste. So preventing waste and abuse by putting certain day supply limits in place. And then third of all, taking advantage of copay assistance programs that are available to shift the cost from the payer back to the manufacturer, because those are readily available to commercial clients. So, what we've seen as, kind of outcomes from our program, we've done our program for 5 years, and it's been really a strong, part of our focus in analytics and savings. What we've seen is that we've actually been able to get the most savings from that autoimmune space, those inflammatory conditions, because it is such a large market right now and it's nearing saturation. And so drug manufacturers are offering lots of assistance and copay assistance to help redirect people to a different preferred product. So because of that, we've been able to kind of capitalize on savings with those manufacturer copay cards.
Yeah, and Nellie, can I add one more thing that I think is a core component, is third-party clinical reviews of each one of those high-cost medications. So when a Humira comes through, and I think you guys may or may not hear this out in the marketplace, is that PBMs are rubber stamping the medication, right? Approving it. And one of the things that I think our team finds is we're pretty close with the specialty pharmacy. And I think they know that we're tracking it. So they're not necessarily rubber stamping those medications. But there's actually a component that not many plans know about. It's actually the physician, because there's something that's called an electronic medical record now. And so the PBMs have utilized those electronic medical records to have the physicians fill out the documentation to approve the PA. And what our team has found is sometimes, not all the times, but about 5 to 10% of the time, the physician has actually filled out the paperwork incorrectly. And so if you don't have a third party reviewing kind of that PA process on those medications, should the member ever actually be on Humira? And again, as we go back to bending the cost curve, it's a lot easier to bend the cost curve when the members are taking the appropriate medication versus, hey, needing to catch up to a new Humira member that may be spending $80,000 a year of plan costs.
Nick, I think everyone liked your other phrase of it, calling breaking the curve. I think that was one that everyone would love to see. I know we're getting close on time here, and so Charlie, I don't know if I've got some other questions, but if you've got something you still want to share, a slide deck or a slide or two, go for it.
I don't. They can read this. Certainly, I just brought it up to give them a feel for what what we what kind of savings we're seeing out there. So no, fire away with the questions. I'd much rather appease the answers.
Yeah, another one that has come up, and just trying to probably just get your feedback, good, bad, or indifferent on this, is international medications. And is that a part of this program? What do you see for the reasons not to do it or to do it? Those types of things.
Yeah, we do have relationships with international personal importation companies. I bring up the word personal as very key to that conversation, because for us, from an employer standpoint, it's not as much about the employer selecting those medications. It's about getting the member on board of getting their medications from Canada, Australia, the United Kingdom, right? And so a key portion of that relationship is, how do we reach out to members? How do we coordinate the cost of the medication? And then at the end of the day is, how do we make sure that they're identifying the right medications to carve out to international sourcing? Because if you're not considering every single detail, and what we found is some of these international importation companies are targeting medications that are about to go off patent, right? And so if you're just trusting the international importation company and you don't have a consultant that really understands the business, they may actually be driving that member to the wrong medication at the wrong time. And so it's a very, very sophisticated conversation, but I think we've identified certain products that we see as opportunities to potentially import, and how to work with the members to get that medication at a more reasonable cost.
And those coordinate with the three main PBMs you guys are working with too, or our solutions works with.
Yeah, so the cost of those medications sits outside the PBM. And so certainly coordinating more with your TPA, who's actually administering the plan. So if there's any cost associated that we need to maybe send to a stop loss carrier, we can do that. But the members' cost, or the members' out-of-pocket cost, is zero.
Right.
So that's the good news, right? So there's no cost when you import the medication.
Perfect. Well, as I think Charlie, you mentioned this is kind of like barely a couple layers of the onion, and it keeps going deeper and deeper. But the information you guys have shared has been awesome and a great start. Again, I think kind of the challenge for folks that are on this webinar and other people that listen to it. I think the number one step is that analysis, to try to figure out what your data means, and to get this information so you can actually dig through it and have your program applied to it to see where the opportunities might be, whether you're integrated, non-integrated, fully insured, or self-funded. And we've had really great success with it. Charlie, thank you to your team for helping us, and Nellie, your folks, and Nick, working the contracts and making sure we stay ahead of the curve for people. So I appreciate you guys, being on the call and taking the time to do this. And we'll share the slide deck with people as long as you guys are okay with that.
Yeah, we're fine with that.
Awesome. And we'll guess take on the next thing that shows up at, in our next hour, right? I guess you guys.
Yeah,
got some snow
absolutely.
over there.
Well, one thing I'll leave you with, just for the folks that are on or anybody's going to watch this later, a proper implementation takes anywhere from 120, 90 to 120 days. So you need to be moving now. May and June are the times that we need to be gathering the data, analyzing it, and producing a opportunity deck for you to preview and to make a decision on. Because if you call us in August, you're behind the 8 ball. So now's the time to be moving. I just wanted to,
Good point.
if there's interest,
Yeah. Thanks
now's
for
the
bringing
time to
that up.
go.
Awesome. Okay. Thanks so much, guys. Enjoy the snow out there.
Oh, God. Thanks. Thanks a lot. All
Talk to you
right.
later.
Thanks,
Bye.
guys.
Bye-bye.